Hey everyone, I'm Jason from Intricate Art Spine and Body Solutions. You can check out our website at intricateartseminars.com. I want to go over today one of probably the most important, single most important manipulation that you can learn to improve pelvic alignment. So one of the most common diagnoses that people get in physical therapy is for a leg length difference, right? And the vast majority of the time, there's no leg length difference, no significant leg length difference, right? So the three primary ways to have a leg length difference is you break a growth plate when you're growing, right, and the growth gets impeded. You have some type of significant structural deformity in your hip, like leg calf Perthes disease or some other unusual thing, right? Or you've had a surgery that's gone wrong and the joint has degraded or something like that. I'm sure there's some other reasons why it could happen, but those are really the primary ones. So unless you've had something like that go on and you're either treating somebody with a diagnosed leg length discrepancy or you have a leg length discrepancy that's been diagnosed, the vast majority of the time that is not true, right? It's an SI joint alignment discrepancy. So what happens is when the ilium gets rotated forwards on the sacrum, right? So we're talking about anterior ilial rotation. The acetabulum gets pushed down towards the feet, so that makes the leg look longer, right? So the most common way for the SI joints to go out of place are anterior and or medially, right? So they can go posteriorly. They can rotate posteriorly, right? And they can externally rotate as well. But the ilium, they wedge into the sacrum. It's like the top of an arch, right? So the top of an arch has a wedge that holds the whole arch together. So as the ilium rotate posteriorly, they wedge into the sacrum. And it's the same with external rotation. It can happen, it's just much less common, right? So the most common, by far, thing that happens with a leg length discrepancy is one ilium is rotated anteriorly in relation to the other, right? And this can cause, let's just say on this skeleton here, the left ilium is rotated anteriorly, so the left leg here would be longer. That could cause right hip pain, it could cause left-sided neck pain, it could cause ankle pain, it could cause all sorts of different types of stuff, right? Because if your leg gets long enough, you're gonna start deviating your gait, right, to accommodate for that. And this, I can't tell you guys how many times I have fixed people that have had like 30 plus years of hip problems just by manipulating this joint back into place, because they've been told they have a leg length discrepancy and it's just been treated as such. So one of the things that I advise against is giving somebody a heel lift. If they have a true leg length discrepancy, you want to give them a full shoe lift, right? And if they don't have an actual leg length discrepancy and you're trying to correct the length of their legs by lengthening the other leg's not the problem. It's the leg that's longer that the hip is out of place. So it's really, really easy to do, and it's super, super simple. And it's one of the best manipulations to know how to do. I rarely do a thrust manipulation with this, so this is just a nice, easy mobilization. This is good for physical therapists, athletic trainers, regular people. Anybody can do this, and it's really, really effective. Okay, so to go about figuring out which ilium is in anterior rotation, it's really easy, right? This is one of the things that a lot of physical therapists, they overly confuse themselves about this, because we learn so many different things in school, right? Like if you go from long sitting to short sitting and the legs change length, that indicates something or other, and then you do all these other tricks. The easiest way is either just pull on the legs or have the patient do a bridge and have them set their butt back down and then look to see which leg looks longer, right? So there's just too many other variables that come into play when you have the patient start moving around on their own and then you start looking at their legs. So when I'm thinking about checking joints, if I can, I always want to be the one that's moving the patient around and not them moving themselves around, because I want to feel how the joints and stuff are moving around. right? So the easiest way to do this is have the patient do a bridge, right? That should kind of level out their pelvis as much as possible. And then I'll come down, and we'll shoot this from another angle so you guys can see, but I just come down here and I'll look to see which foot is longer, right? Which leg is longer. And then that will tell me that most likely the leg that's longer, that ilium is going to be anteriorly rotated, right? So if the left leg is longer, the left ilium is anteriorly rotated. So as you can see here, we've had the patient do a bridge, and then if you can see, right, the left leg looks longer, and if you can make it more obvious, right, just to kind of over exaggerate it, but you're going to want to come down and look at the feet and just see which leg looks longer, and then we're going to assume that that longer leg, the ilium is anteriorly rotated on the sacrum. Okay, so we've figured that the left leg looks longer, so we're assuming that it's anteriorly rotated. So this is the primary position that I like to do this technique from, right? So I'll have the patient roll on their side so their longer leg is up, right? So the patient roll on their side, longer leg is going to be up like that, right? And I like to get in between the patient's legs like this, because just by, if my hand is the ilium, just by flexing the hip, I'm posteriorly rotating the ilium, which is what we're going for, right? So we're trying to posteriorly rotate the ilium, which brings the acetabulum back up to where it needs to be, right? So my hand placement for this is one hand on the ASIS and the other hand on the inferior aspect of the ischial tuberosity. So if you're not on the very bottom of the ischial tube, you don't get enough kind of rotational force going through there, because if your hands are so close together, you're not going to get a good rotation. You want them farther apart, and then you're getting a good rotational, posterior rotation of the ilium. So you have your hand on the ASIS and you have your hand on the ischial tuberosity, right? So I'm bringing my whole body up to flex the hip, and at the same time I'm just pushing like this with my hands, right? So the key with this one is to take up the slack of the SI joint. So now the slack's taken up, and I just usually like to do little oscillations. And if you have a bigger patient than you, just kind of lock your arms in that position and rotate your whole body and use your legs, right? So instead of trying to just rotate with your arms, keep your arms locked and rotate your whole chest, and that makes it a little bit easier. So for a different angle on the hand placement here, right, so we have the longer leg is on top. Just by flexing the hip, we're posteriorly rotating the ilium, right? So I put one hand, just make your palm nice and soft, because it can be a little pinchy on some people's ASIS. So one hand over the ASIS, one hand over the inferior ischial tuberosity. And then if you put your forearms in the line of force you want to go for, it makes it a little bit easier. And then you just rotating and taking up the slack, and then I move my whole body up as well, and then you just take the joint to end range and just oscillate the joint back and forth a little bit, and that should correct the anterior rotation of the ilium. Okay, so we corrected the anterior rotation of the left ilium, right? So now to see if what you did was successful, just have the patient redo what you did the first time. So have the patient do a bridge, and then I'll kind of just even them out a little bit more by pulling on the ankles, and then I look and I just see that now the feet are in line with each other, right? So this is fixing leg length discrepancy. So again, I've had tons of patients that have had a leg length discrepancy for decades, and they come into the clinic with low back pain or SI joint pain, and you do this manipulation and they're 100% better, and their leg length discrepancy is magically gone. So it's a really, really great technique. So another thing to keep in mind is if you have a patient that's a lot bigger than you, or if you're just trying to fix your own hip at home, you can do this on at the corner of a hallway, or if you have a pole, or on the end of a couch or something like that. Again, or if the patient's a lot bigger than you, you use the patient's own muscle strength to pull their own hip back into place, right? So this is going to be using the hamstrings to posteriorly rotate the ilium back into place. So I'll have the patient roll on their side, right? And then when you get up here, you really want to make sure that the hip is past 90. If it's not past 90, you don't get as good of a pull through the hamstring tendon because of the angulation going over the ischial tuberosity. So hip over 90, have the patient push into you for 5 or 10 seconds like that. Have them relax, and then I'll increase their hip flexion and have them do the same thing over again. And each time you do that, you should be posteriorly rotating the ilium back towards neutral. Okay, so remember the two easiest ways for the ilium to go out of place is anterior rotation and or medial rotation. So the order that I do it in is I check for anterior rotation first and correct that, and then do medial rotation. I don't have any real rhyme or reason for that, so you can do it in either order. This is just kind of how I've always done it. So again, there's a whole bunch of different ways to check for medial rotation of the ilium. You can check the PSISs, and then you can go around and check the ASISs. And to me, it's just makes sense, and it's easiest just to look at the relation of each ASIS to the belly button. So you're looking to see which thumb is closer to the belly button, right? So it's hard to see from this angle, but my right thumb on the left ASIS is much closer to the belly button than the patient's right ASIS is. So again, I just use the easiest mechanics. So the left ASIS is closer to the belly button. The left ASIS was also the one that was anteriorly rotated to begin with. This can happen in either direction. So a lot of the times I'll see left ilial anterior rotation with right ilial medial rotation, or vice versa. It just kind of depends, but this happened to be left anterior ilial rotation and left medial ilial rotation, which is also very common. So to correct for left ilial medial rotation, the easiest way to do this is just pull the patient towards you until the ASIS comes off the table and push the ASIS away from you, right? So remember, the SI joint in the back is like a triangle, like my hands here, right? So the left SI joint is at an oblique angle, just like my forearm here. So instead of pushing straight laterally, it actually works a little bit better if you push a little bit obliquely in the inferior direction. So if you think about pushing perpendicular to the SI joint in the back, that really helps. So this one, again, I think people overcomplicate a lot. They'll have the patient kind of side bend away or side bend towards them first. I've always had success doing it this way, just with the patient in neutral, and it just seems a lot easier. So the way that I like to do it is I'll grab on the patient's scapula there, and I just pull them towards me until the ASIS comes off the table. So if you're going to do the manipulation from there, you're just pushing the pelvis directly into the table. You need to pull the ASIS off the table a little bit, and then I'll just do some oscillations. And then remember, my angle of force is kind of that way. You can go straight lateral. It works a little bit better if you go a little bit inferior lateral. So your palm's right on the ASIS. I just do some oscillations, and then you just thrust down, and you'll get some lumbar cavitations out of this one as well. Okay, so we just went over how to correct for SI joint deviation. If you guys like our technique and our style, we'd love to see you at a class. Check us out at intricateartseminars.com.